So next thing is the clinical audits in non-gynecological cytopathology. The characteristic of the clinical audit in non-gynecological cytopathology, the accuracy of the non-gynecological cytopathology is usually checked against the follow-up histology by using small biopsy or excision specimen. However, sometimes it is used on its own for making a diagnosis without histology. Then its accuracy should be measured against other diagnostic tests or clinical outcome. When pathological material is small, as a small biopsy, comparison with the cytology of the case may not be accurate, since the small biopsy may not be represented the entire lesion. Right, the accuracy of the specimen and the proper smear preparation and the staining is essential for effective cytology reporting. Therefore, non-gynecological cytopathology audits should take into consideration technique of taking the specimen as well as the preparation and staining in order to assess the sensitivity and the specificity of the gynecological diagnosis, especially in malignancies. It is essential that audit assesses proper recording of results and follow up. The use of terms such as suspicious, equivocal, and the probable malignant or probably benign in reporting should be defined, assessed, and compared with outcome. Cytological preparation are difficult to duplicate or reproduce. Therefore, slight exchange and measuring of inter-observer verification is more challenging than with histology. In center where the cytoscreener or trained cytotechnologists do the preliminary screening of the smear, their performance should be audited and compared with that of the cytopathologist. Cytology is a cost effective test. However, to obtain an optimal cytology service, there should be sufficient resources for the technical staff to prepare good smear, enough time, and the resource for training postgraduate students in aspiration techniques, and adequate time for reporting. These should be assessed in an audit. Why should the non-gynecological cytopathology audit be done? So, cytology is an essential and inexpensive, quick technique with relatively minimal complication, high sensitivity, and specificity if practiced with experience and care. However, it is effectiveness is compromised by faulty technique or inaccurate diagnosis. Cytopathological reporting is only as good as its value in clinical management. In non-gynecological cytopathology, audit should be identify and correct area where it may not be meeting its full potential in clinical values. An audit should contribute to the training and the continued education, comparing the cytology with its corresponding histology specimen results directly contribute to such training and education. Audit should identify areas where the use of cytology should be extended or limited so that the available resources for cytology can be used in a more clinically relevant and effective way. So, next is who should be involved in the non gynecological auditing. The physician, surgeon, radiologist, cytopathologist, junior medical staff, uh, pathology trainee, technical staff, nursing staff, and any ancillary staff who are involved in specimen taking, transport, preparation must take a part in the auditing. Hospital doctors and the general practitioner who will be managing these patients should be involved in auditing the clinical usefulness and application of non-gynecological cytopathology. For example, the breast and the thyroid FNAC can be used to provide rapid diagnosis in clinic, thus affecting the patient's referral pattern. Hospital administrator and purchasers should be involved in auditing the availability, effectiveness, and cost of non-gynecological cytopathology. Technical staff should be involved in auditing preparation techniques. If they also function as cytoscreener, they would also be involved in auditing diagnostic accuracy along with pathologist and the pathology trainee. Clinician of relevant specialists should be involved in the audit of diagnostic accuracy when compared to clinical outcome. Histopathologist or the cytopathologist and their trainee should be involved in all aspects of the audit, especially to audit the accuracy of the histology with which the cytology results are to be compared. If the special tests such as immunohistochemistry, molecular biology, or the cytogenetics are carried out on cytology material in referral laboratory. Correlation with cytomorphology is essential to achieve accurate diagnosis, and also clinician, pathologist, and technical staff involved in ordering, performing, or the reporting the results and the cytology should take part in auditing these. Defining the scope of the non-gynecological cytopathology auditing. While audit is necessary to maintain standard in non-gynecological cytopathology, audit can be a framework for other good quality assurance practice. That means histological correlation with mm, cytology is done in many instances. In clinical audit, this is analyzed so that clinical effectiveness and the accuracy of cytology may be monitored and improved. Multiple disciplinary meeting and the clinical pathological conference are a necessary part of decision making on management of involved individuals patients. They are also a forum for clinical audit. External quality assurance scheming are not currently available for non-gynecological cytopathology in our country. Now, even in this West, only a few non-gynecological cytopathology external quality Assurance schemes are available, such as breast and the cervical cytology. Therefore, qualitative assurance in non-gynecological cytopathology largely depending on the auditing. Unlike histology, non-gynecological cytopathology is only routinely used in a few instances for diagnosis. For example, breast or the thyroid masses, or some countries in screening program. Hence, audit is necessary in order to improve maintaining of standard in non-gynecological cytology for laboratory accreditation. So, when we consider the implementation of clinical audit in non-gynecological cytopathology, first prerequisites of for the doing an auditing. So, accurate record of the test, indication for the cytology, name of the persons involved in each step, for example, obtaining sample, preparation, smear, producing the report, like that. The computerized report will be a more effective and easy to use. If a code number is given for each type of diagnosis, for example, C1 to C5. During audit, it will help to assess the cases with doubtful or equivocal descriptive reports or accurate correlated with clinical outcome. Or cases where the interpretation was difficult should be flagged or marked for subsequent correlation with the histology. If a preliminary cytological assessment is done before the final assessment, for example, imprint or smear of the histological sample or reporting on a direct smear before preparing a cell block, these results should be mentioned in the final report. Where the cytology and histology samples have been taken at the same time, these reports should be correlated before implementing any clinical management. For example, pleural fluid and the peritoneal biopsy, sorry, pleural fluid and pleural biopsy, uh, bronchial washing or brushing or biopsy, or FNA and the core biopsy are the example of this. They are the additional tests such as cell blocking, immunohistochemistry have been ordered. The first reports on the cytology should indicate that such have been ordered and that a supplementary report would follow. Next, mechanism of doing an auditing. So, analyze the accuracy of the non-gynecological cytopathology. That means sensitivity, specificity, false positive and negative rate, positive and negative predictive values, and a slide exchange scheme with the analysis of inter-observer variation in assessment. Multidisciplinary specialist group for cancer center and unit involved in center care. These should be used as a network for setting up and implementing non-gynecological cytology auditing. Through the College of Pathologists using a published quality assurance guideline as audit protocol, currently available for histopathology only, but containing some principles that can be applied to cytology also, or the participating in any future multi-center audit studies conducted by the college. Then resources for the clinical audit in cytology. Clinical audit is the time-consuming process, and other than the materials such as the stationery and the computer, human resources such as data collector, statistic experts are needed. This could be require a source of funding. So, authorities such as the Health Ministry, Family Health Bureau, or other funding agency approved by the authority should be appro- approached for funding of an auditing, especially for gynecological cytology and in type of non-gynecological cytopathology, which are routinely important in patient management, such as, for example, breast or thyroid cytology. When budgeting for the purchasing supplies, it should include uh, financing of clinical auditing cytology. The roles of professional bodies in cytology auditing. A professional body uh, in charge of standard in cytopathology, such as the College of Pathologists or collaborative where necessary with the Board of Study of the Pathology of the Postgraduate Institutes or Family Health Bureau and the relevant ministry. They could establish an audit committee or set standard or guideline for audit in cytology in case of both gynecological cytopathology and the non-gynecological cytopathology. Maintain a database of successful audits or the published guideline. Offer advice on designing, contacting, or the funding an audit. Coordinate and identify funding sources for national audits. Include audit in core training program in pathology and medical laboratory technology and monitor the participation of trainees in audit through annual review. Identify the time for audits in the job description of a consultant pathologist. These are the uh, we already discussed. These are the um, roles of role of um, professional bodies in the auditing. So these are the references. Thank you. So next we will move into cervical cancer classification. So we will meet next. Thank you.